Welcome back, folks who are watching online and CTAF, patient experts and clinical experts. So as I mentioned, we are now going to head into a phase of further deliberation on specific voting questions that will tee us up then for our policy roundtable. And we have clinical experts and patient experts at our table, so virtual table, so that we can get their input as we consider the following. Next slide. So for the first clinical voting question, it's important to note the patient population is patients with lower risk MDS without the del(5q) mutation who are transfusion dependent and ineligible for or refractory to ESAs. And you can see the definition of transfusion dependent. This is all taken, obviously, from both the clinical trial criteria and the FDA label. So all patients, if you will. Let's go ahead and see the voting question. Is the current evidence adequate to demonstrate that the net health benefit of imetelstat plus best supportive care is superior to that provided by best supportive care alone? Jeff, you presented the data and information this morning. Do you mind briefly recapping that and another kind of description of the thought process or the rationale behind what the research team gave us its rating of clinical effectiveness?
Yeah, we gave it a promising but inconclusive. The key tables in the evidence summary that you want to look at are Table 4, the iMERGE trial key results, and Table 7, the key harms. And again, here we're just focusing on the iMERGE trial. All the data really come from that trial. So the major benefit is this transfusion independence at 8 weeks, 16 weeks, 24 weeks, about a 25% difference between the placebo group and the imetelstat group. And then for those who do respond, again, it's less than half of patients, but among those who do respond, the median duration of response was 52 weeks, so about a year, versus 13 weeks in the placebo group. So clear benefits, no difference, no statistically significant benefit, thanks to our colleagues at Stanford. I will say I did calculate it as well. I just I feel like I need to stick to the evidence reported, so no statistically significant difference in fatigue, progression to MDS and AML. And, again, probably just noise, but as several folks commented on during the meeting, the mortality is nominally higher in the imetelstat group. So clearly no mortality benefit, at least in the short term. Harms, I don't need to belabor it, more hematologic harms, significantly more, sort of balancing out the clinical benefits. So lots of people get no benefit, but get harms. So some promise, but it's definitely not a home run from our perspective.
Got it. By the way, I should have noted, I know the whole country or world is dealing with a technology snafu today. I'm dealing with an old-fashioned one, which is I'm somewhere where the web is a little bit dodgy. So if I kind of go wobbly here and you can't hear me, hopefully I'll come right back in pretty quickly, but please don't hesitate to throw things at me virtually if you're not able to hear me clearly.
And of course, Steve, one of the fixes to that is just go off video if you start to have problems, because audio bandwidth is much less than video. But you've been fine.
How can you do without seeing me, though? I'm not sure. I need to see you, though. Okay, I want to ask a provocative question. I want you guys to start to tee up your questions. You asked good ones this morning. Clinical experts, we have the evidence before us. When people are thinking about the net health benefit, are clinical experts thinking that this has any reasonable likelihood of delaying progression to AML or to higher risk MDS? We can argue about the evidence behind it, but I'm curious what your take is on the clinical expert community. What are they thinking?
I have an answer to that. Andreas, to you.
Yeah. Go ahead.
I mean, sticking strictly to the trial, right? I completely agree with the assessment. We don't know, right? It's small trial, relatively short follow-up in a low-risk MDS population where you need more time for events to accrue and things like that. So from the data, we don't know. I did want to bring up one element that we really haven't discussed at all that does give me some hope. I think it's intriguing. This gets into the weeds a little bit, but there's genetic data provided in the publication and also in the phase 2 report showing pretty compelling reductions in the size of the malignant clone. Essentially, the mutations and the chromosomal abnormalities get less severe in many patients, and that was correlated with transfusion benefits. So the deeper your molecular response, the more prolonged your hematologic response. They were correlated. That gives me some hope that this drug is actually having impact on the biology of this disease, which could translate into some impact on the long-term natural history of the disease.
All right, Andreas.
Absent polling all of my colleagues, I think I think Tim makes a really good point. I think no benefit is proven, or no difference in the evolution to AML is proven. Our other alternatives, luspatercept and the ESAs, neither of them affect the biology. They affect a bit the survival of red blood cells or cause you to make more of the diseased red blood cells that you have. But this drug has by counteracting the tendency of those cells of the stem cells to lengthen the telomeres and protect themselves. It's actually working, at least in theory, on a level which could affect biology.
Is it not impossible that, I mean, with some tumors, we have felt in the past other situations where we are treating the biology and it seemed to suppress the primary mutation only for a more aggressive one to emerge later, leading to an overall no change in survival kind of outcomes. You guys are very familiar with that. Is that somewhat possible here?
I would say so.
I would say anything is possible, but the difference, the example you give of oncogene-driven cancers where you're using a targeted therapy against that mutation, the cancer will do anything it can think of to circumvent that. Here, these mutations that are going down are not the direct target, presumably, of this drug. They're just the clone. The size of the malignant population is shrinking as a consequence of the drug. So maybe there's a little less selective pressure that would cause the tumor to acquire, bypass mutations. But this is all very speculative and time will tell.
All right. Thank you for humoring me. I know we were outside the evidence, if you will, but I thought it was helpful to hear that perspective. Let's have comments and questions from CTAF members before we get teed up for a vote. Jeff?
Thank you. I wanted to ask the evidence review team, after reviewing the evidence, what was your thinking behind characterizing it as P/I instead of I?
I guess there's pretty clear evidence that it impacts anemia, which is really what it's targeting. And there are patients who, luspatercept no longer works, or they're ineligible for luspatercept, who really have run out of options. And this, for a minority of them, it may have a long-lasting clinical benefit, but there are a lot of harms to it, and it's just one small trial. So I would not, I didn't give it clear evidence of benefit, but there are some promising features. The fact that the expert community was not concerned about the grade 3/4 hematologic adverse events in the advisory meeting. 2 were, 12 weren't. And the fact that, at least in the clinical trial population, we didn't see an excess of really clinically meaningful consequences of those. That was my thinking. It was, but you guys can definitely go either way on this.
If I could have a follow-up question, I'm looking at key harms table 7, and I go to the row called anemia, and I see that regardless of the flavor, I think what I see is that people with the new drug have a greater chance of anemia. Am I understanding that right?
Yeah, of grade 3-4 anemia, yes. So,
Okay.
I mean, I think there's a heterogeneous effect. Some people, I mean, some people get worse, some small subset get better. I mean, we heard some who have transfusion independence now out 2.5 years, small population, but yeah.
Super, thank you.
Okay, Saidi.
Steve, thank you for opening the gates to my speculation. So one of the things that I was thinking about in terms of, and I would love to ask the clinical experts, is it strikes me as telomeres and telomerase is going to be present in many cells besides bone marrow cells. And so are there other signals kind of, again, these are going to be presumably much earlier stage, maybe animal models of adverse effects that we may see only after years of using this. So what are the other kind of target tissues that this might potentially adversely affect?
That's for Tim or Andreas. There you go.
Oh, I'm sorry, I couldn't really comment.
I would say I don't really have sufficient expertise in telomerase biology to make a intelligent comment on that. I would say, as a bystander in this field, I think we do need more evidence that that's actually the mechanism of action of this drug, to be honest. I think we really need to continue to study that in patients and in models to really more convincingly show that the benefit is due to inhibition of telomerase.
Thank you. Rita?
Got it. I'm off mute. Sorry, I have two screens in. Thanks. I have a few comments. One, as others have said, I have a lot of concerns about the data, both that there didn't seem to be a difference really in fatigue, that there wasn't a difference or even measured quality of life, which I think was our goal for this drug, was to have a quality of life benefit. And to note that I think transfusion dependent, as I said earlier, is a very subjective endpoint, because any treating doctor can determine when to give a transfusion, and that means they're dependent. So, and that you are trading that off for an infusion every 4 weeks. So that's like having a transfusion. You're still having the caregiver take you to the center and getting this transfusion. That doesn't include the fact that 91% of the people taking this drug had a grade 3 or 4 neutropenia, which again is going to require additional visits and treatment. So I'm seeing very little quality of life benefit. I'm all for more options, but I'm only for more options when they actually offer something better than what we already have, and I'm not seeing that data. There was the increase in deaths, which these were small numbers, but still certainly an important signal and one of concern. I will say that, you know, I'm a cardiologist, but is this age group, is the patients I see in my cardiology practice. I've taken care of patients with MDS, and what I see is similar to what Rochelle Mackey shared with us about her husband. You know, the people are identified as having MDS based on a CBC that was done for other reasons or no particular reason, and they become very anxious now because they're told that this could be a precursor to a blood cancer. And so there's a clear decrement to patients. This is not related to Immelstat, to making the diagnosis on all these screening tests in the first place, which I think could accelerate the path to symptoms, though, once you've told someone that they have, and this is what could happen. And then it's disturbing to me that the data wasn't sent when requested from the company. And finally, I find it a sad comment on our healthcare system that a drug with what seems like so little benefit could hit the market at such a high price. and there's really some bigger problems in our system and doesn't seem sustainable, and certainly not for Medicare or for the system overall. Thanks.
Okay. Price and value will be coming up as a future voting question, as you know. Okay, I'm going to be sensitive to our time for other questions. I was going to ask Joan or Dina anyway to comment on the patient's perspective of the balance of benefits and harms here, the neutropenia, the increased risks, which are quite substantial in terms of the percent difference. And so help provide your perspective, if you will. And you might have wanted to say something else, but I want to encourage you to also comment on that, please. Joan, go ahead.
Yes. In reference to a transfusion compared to having this drug, I would say 99% of the patients that have transfusions, we don't want transfusions. You got to go and you got to get cross-matched. Then you're at the facility, be it a hospital or someone else, and you're sitting in a chair, possibly from 4 to 8 hours. So we're looking for an alternative. Going in there for that one day for the infusion, we'd rather do that than have all these different blood transfusions, because I mean, so far, most of us are fortunate that we didn't have an adverse reaction to the transfusions, because blood is blood. But no, if you give us the opportunity to have a medication, I think 99% of us would say yes, because we don't want to. Some people have to have transfusions every week. I was fortunate when I started, it was I believe every 2 weeks I had to go in, and that was like, I had to get blood tests during the week to make sure my blood was this and that. And I mean, it took away from my quality of life. So when they had the medications such as what that I'm on now, I welcome the fact that one day a month I get to see my doctor. I get to have my my treatment that day, and adios, another 21 days, then I'll see him. But going to the hospital or the center for transfusion, I don't know if anybody else here has had transfusions other than patients, but it's not fun. It's not fun.
All right, thank you very much. Okay, Rena and then Deneen. Good, and we'll take a vote after that. Rena, go ahead.
A question for the experts. I think, you know, we're seeing this is not a drug for fatigue. This is a drug that could potentially reduce transfusions, and transfusions are not benign. So one of the risks of transfusions are the iron overload. What degree of transfusion reduction would you need to see to prevent the overload that, you know, has been emphasized as one of the biggest risks of repeated transfusions?
No, I think fine. That we see clinical. We think we are at risk of clinical iron overload after about 20 transfusions. The body, we have no natural mechanism of expelling iron from our bodies. We lose it only by sloughing skin cells that we, as animals, hold on to iron very tightly. So we need these chelator medications which bind the iron in the circulation and then allow it to pass out through the liver or pass out through the urine. And so there, it's sort of an cumulative effect. And any way we can reduce giving one more unit of blood helps reduce, helps to reduce that impact, because it just keeps adding up and adding up and adding up. It's not like we have a steady state where we can match a number of transfusions against how fast we can get, naturally remove the iron.
So I think, and Jeff Tice asked this earlier in the day, do you see this fitting in for prevention of overload, for rescue from overload? How do you imagine that would be? How does that come together in practice?
I think it could facilitate avoiding iron overload. It can facilitate the clearance of iron just because you're not adding more to the pool as you're trying to empty the pool with a teaspoon. You're not putting a cup worth of iron back in every time with a transfusion. So sort of in the scheme of things, by reducing the number of transfusions, you are facilitating the overall removal of iron. It just is, it's easier to do if you're not continually adding more.
I will say
Okay, thanks.
it's a minority of patients who probably get that benefit. When you look at the whole population, I love table 8. The total number of transfusions over the lifetime is 159 with best supportive care and 149 with imetelstat. So net on a population basis is not a big difference. For some individuals, it clearly will be a huge impact.
Okay,
Thanks.
Deneen, I am going to move forward and let Deneen make the last comment. Lisa, I'm sorry, we're going to have to take a vote after that. Deneen, go
Thank
ahead.
you. Yes, thank you. So what I wanted to say, so cancer support community, in our engagement with individuals impacted by cancer and those that we surveyed impacted by MDS, what we know that matters to them, we know it's broader than survivability. It's even broader than just, treatment side effects. But what's also important and what I want everyone to remember and to consider is patient experience, right? Patient experience as it relates to that treatment. And so what I would encourage you all to think about is when you decide on the efficacy or the value of this treatment, that when we think about patients, it's really important that we have their experience throughout the process, meaning what does meaningful access, what does meaningful treatment mean to me? And so what we know is that individuals with MDS, they are deeply impacted by quality of life changes, and having the availability of a treatment that will allow them to, we talk about fatigue, we talk about having to go to a center less often for a transfusion. That is really important to them. And when I talk about value, what it means to each unique patient, we have to understand that I believe in patients being informed and empowered to have those informed decisions and conversations with their doctor to be able to decide what treatment it makes the most sense to them vis-a-vis the side effects and what their goals are for their life. And so I just want to raise that with the group to say that, individuals impacted by MDS, they oftentimes, they know about their disease, they learn about their disease, they are aware of the side effects and the risk of benefit versus complications, but they should be the ones empowered to have those conversations with their care team and their caregiver.
Okay, thanks. Lisa, I am sorry. I really am going to have to go ahead. Or we're going
10
to.
seconds. It can be 10 seconds. Infusion is 2 hours. Monitoring per the package insert is weekly blood draws for the first 2 cycles. So that's 8 weeks of weekly blood draws coming into the lab because it's approved. We have the package insert.
Okay, thank you. All right, please put up the voting question, which you remember again. Please take note in your minds, at least, of the patient population. And please vote yes or no. Is the current evidence adequate to demonstrate the net health benefit of imetelstat plus supportive care is superior to that provided by supportive care alone? We have 15 voting members. Okay, results are 4 yes and 11 no. All right, let's move to the next voting question, which again, we need to note the different patient population here. It is still patients with lower risk MDS without the del(5q) mutation who are transfusion dependent and ineligible for refractory to ESAs. But now we're also talking about those who are ring sideroblast positive. All right, and the first voting question is going to be for that patient subpopulation. Is the current evidence adequate to demonstrate that the net health benefit of imetelstat plus best supportive care is superior to that provided by luspatercept plus best supportive care? Okay, Jeff, why don't you please quickly recap where we are?
Sorry about that. Table 3 is the baseline characteristics, not we asked for the ring sideroblast subgroup baseline characteristics. We don't have them, but even when you look at overall, they're remarkably similar, some small differences, but addressing the issue of whether we can even do an indirect comparison. And then the benefits are tables 5 and 6. And the harms are table 7 again, this time looking at the additional columns for the medalist trial, so luspatercept. And you see, as was pointed out, for luspatercept, there's really no increase in adverse events compared to the placebo group, whereas we see clear harms with imetelstat. And so, I mean, there in terms of the harms, clearly luspatercept appears to be safer. The benefits, you see about the same absolute benefit in terms of reduction in transfusions, and nothing else that we know about that's any different between the drugs. So about the same benefit, worse harms. The data are indirect, small trials. We don't really have all the information we'd like to make it, but it certainly doesn't look any better. But we really feel like we don't have enough of the data to say anything with any confidence. When you look at the network meta-analysis, the confidence intervals comparing the two are quite wide. So insufficient evidence, but no evidence that it's better, and maybe some evidence that it's more harmful.
Questions from the CTAF or comments? All right, we sometimes get a lot of the bigger issues out on the table with the first voting question as it is. In this case, it's basically an imetelstat versus luspatercept in this patient population question. We'll come back to the insurance and clinical decision-making and other aspects of this comparison when we hit the policy roundtable. Why don't we go ahead and do the vote then? Okay. Yes or no, is the current evidence adequate to demonstrate that imetelstat is superior to luspatercept in terms of net health benefit? Okay. 15 no, 0 yes. All right, we can move forward then. All right, just a quick preview for those watching and who have not been part of an ICER meeting before. In addition to clinical questions and a kind of overall question on value, ICER's value framework, as Sarah Emont mentioned this morning, it incorporates the idea that there can be sometimes benefits beyond health and special ethical priorities that kind of add to our broader view of value. And so we have a series of questions to ask, both about the condition itself and about the relative effects of imetelstat to help add to our broader thinking of value before we take that final value vote. So let's look at the first voting question. I'm sorry, I should note again, we have to be clear about the patient population. This one is if I will, all patients again. I'm not going to read it again. This is not just those with ring sideroblasts, so we can move forward, I think. So, as I've described, to help inform judgments of overall long-term value, we're going to ask the CTAF panel to indicate their level of agreement with the following statements. First voting question is, there is substantial unmet need despite currently available treatments. Voting from 1, strongly disagree, to 5, strongly agree. We have heard about this from a clinical perspective. I just want to invite Josh to quickly, if you will, represent the information on health shortfalls due to this condition, and then we'll open it up for questions or comments before we vote.
Sure. As we recall, we had information about the absolute shortfall, the proportional shortfall. It was around 9 in terms of an absolute shortfall. That is essentially comparing patients with this condition in terms of the amount of the EVL-YGs that would be foregone as compared to a general population, and out about 75% in terms of a relative number. And that compares, I think it was approximately around similar to Alzheimer's disease. Again, that's around the patient population themselves, not necessarily the anemic component of that.
Okay. Anybody want to make any comments or questions to clinical experts, patient experts about this question, or are we ready to vote? All right, I'll take that as a chance to gain some time. Why don't we go ahead and vote then and make sure you get the scale correct. 1 is strongly disagree, 5 is strongly agree with the statement there is substantial unmet need despite currently available treatments for the patient population that I mentioned. All right. We've got 7 strongly agree, 7 agree, and 1 neutral. All right, so relatively high on that scale. Next question. For that same patient population, from strongly disagree to strongly agree, this condition is of substantial relevance for people from a racial and or ethnic group that have not been equitably served by the healthcare system. Jeff, I think, why don't you just briefly
Yeah.
again
I
summarize?
mean, we didn't see any,
background.
we didn't see any racial or ethnic disparities in this illness. And other than, you know, it is an older population, but no race, ethnicity, significant differences.
Okay, Anna, yeah, go ahead.
Yeah, I actually clicked on the link that you guys provided to the CERS data, and so the incidence is about twice as high in white people versus people of color. Of course, it's an older population, so that sort of, I would assume that all of these patients are more resilient, both in terms of their lifestyle and their health, to be able to get to the age of 70. But just wanted to note that it certainly occurs in all racial and ethnic groups, but it is more common in white, non-Hispanics.
Okay, let's go ahead and vote on that question. So from strongly disagree 1 to strongly agree 5. Condition is of substantial relevance for people from a racial ethnic group that have not been equitably served. Okay, votes are 4 strongly disagree, 2, sorry, I keep saying the number, 6 disagree, and 4 are neutral, and 1 agree. All right, let's go to the next question. All right, so now we are going to shift conceptually to not thinking just about the condition itself, but about the relative effects of imetelstat. And again, this is just to help people flesh out what some people consider to be broader effects that are important to patients and families and society, perhaps, and are not, if you will, directly captured in short-term clinical data. So the first voting question is, sorry, again, back to the patient population. The first couple of questions will be about the all, if you will, all comers with MDS who meet these other criteria. Next slide. Okay. Strongly disagree to strongly agree. The treatment, imetelstat, is likely to produce substantial improvement in caregivers' quality of life and or their ability to pursue their own education, work, and family life. We had, I think, some important perspectives on that presented during the public comments. Wanted to invite, again, Deneen or Joan, if you'd like to comment on, again, it's tricky because we're asking the CTAF to think of 2 things. One is whether there is a big caregiver effect of having MDS, and the other is whether imetelstat is likely to have an important spillover effect for those caregivers. So I will already foreshadow that a no vote here does not mean that people don't think that there's an important caregiver effect. It may just be that they don't think imetelstat is going to do much to affect that. But let's hear patient perspectives again on the family and caregiver aspects of this. Joan or Deneen?
Yeah, I don't have a caregiver. I live by myself. I have 2 sons that are on the East Coast. So, you know, they are concerned, but I don't need I'm at a point right now that I don't need a caregiver, but I do run 2 support groups. And a lot of times the caregivers will get on the conversation and say, this is very taxing to us. Our life has been turned upside down. A lot of plans that we might have or things we want to do, we can't because we have to be there for the patient. So I will say yes, that even though this drug is not the cure-all, the fact that if it gives them an option that they don't have to go back to the hospital for transfusions twice or 3 times a week or whatever, I think it would be of some support as another option. Thank you.
Yes, I agree with what she said, and want to echo, you know, based on that survey we did of MDS respondents, about 59% of them did have caregiver support, and about 40 or so percent did not. And, you know, of those who did not have caregiver support, a lot of them mentioned that they would have liked caregiver support with respect to household chores, medical care, transportation, and managing symptoms. So we can imagine that those who did have caregiver support, that's the additional, you know, support and resources that they are providing. And so one of the major themes that come out of our cancer experience registry surveys, even with cancer caregivers, is having that opportunity, not just for the patient to have a better quality of life, but also for the caregiver to feel comfortable and empowered and not guilty that if the medication helps provide some sort of relief or lessens an adverse quality of life, that also then transfers to the caregiver as well with respect to their health. That's mental health, that's physical health, that's with respect to their social inclusion. So there is a societal effect, quite frankly, that I think when you look at whole person care and you look at the whole person, you can't negate the effects that a treatment could provide to a patient that could then be not expressed, but experienced by the caregiver. So I do believe that that should play a role as well and be considered.
By the way, ICER has often commented that we wish it were more common for clinical trials to capture caregiver effects, both on the good and, if you will, the downside, because again, here we think of fewer transfusions, but with, you know, more than 2/3 of patients having neutropenia at a significant level, maybe that triggers more caregiver interaction with the healthcare system. It would be helpful if we had those kinds of data to put meat on the bones of some very important questions. Lisa, go ahead.
I'm just going to more slowly say what I said before because I think it's relevant here to make sure that everyone understands. So for example, Joan, the medicine, the luspatercept is a subcutaneous injection. So that is much easier. This is different. This is a 2-hour infusion. So you're still going to the infusion center and having to get set up and get the IV and everything like that. And like I said, the monitoring, at least for the 2 months, is weekly visits to the lab to get your blood drawn for 8 solid weeks to see if you're having these pretty severe adverse effects. So just wanted to be clear, there's a big, I know the comparison question is the next question, but when we think about this kind of time for family and caregivers and things, it's not as easy as a single subcutaneous injection where you're in and out of the office, unfortunately. It's much longer.
Thank you, Lisa. Annette?
Just a clarification, I understood from Andreas that luspatercept, although it's subcutaneous, it is administered in the clinic. So they are driving in to get it injected every 2 weeks. Is that correct? Or is it a home injection?
But you don't have to go to an
That's-
infusion center, I think.
That's correct. It's not self-administered or home administered. And I know that the pharmacy, this is not relevant to this guy. It's not an easy drug. There's definitely prep time. And there are also side effects, the luspatercept that we haven't talked about. But in any case, the answer is yes, you have to come to a facility.
And do they have to do it under controlled circumstances? So for instance, in my field of neurology, so drugs that can cause acute side effects, they are administered typically in the infusion center rather than by like the nurse's clinic that might give somebody with a hand dexterity issue their injections.
At our center, yeah, it's given in an infusion center, same as it would be if it was an infusion or a transfusion, but that may not be true widely. I don't know.
And as you said, we are having the same question comparing imetelstat to luspatercept in just a second. So hang on to that thought as well. Okay, why don't we go ahead and go back to the voting question and reminding you again to be just cautious that you've got the scaling correct, with 1 being strongly disagree to 5 being strongly agree. Do you think the treatment, how do you react to the statement? The treatment is likely to produce substantial improvement in caregivers' quality of life and or their ability to pursue their own education, work, and family life. Everybody check to see if your vote went through. We've got one still pending. If we don't get it, we will go ahead in a second, though. There we go. Okay. 7 disagree, 5 are neutral, 2 agree, and 1 strongly disagree. All right. Noted. Let's go to the next question. Again, for the all-comers population here. How do you react to the statement, the treatment, imetelstat, offers a substantial opportunity to improve access to effective treatment by means of its mechanism of action or method of delivery? Jeff, just remind people of what they already know, pretty much.
Yeah, I mean, it's an IV infusion. You have to come in. So it's not offering any benefit over the other, luspatercept or ESAs or other things. I don't think there's much more to say there.
I don't think so. All right, let's go ahead and vote. I want to give us time to wrap all these things together in a more complicated value vote. Please vote again from 1 strongly disagree all the way up to 5 strongly agree. Do you think the treatment offers a substantial opportunity to improve access to effective treatment by means of its mechanism of action or method of delivery? Okay, 7 disagree, 6 strongly disagree, 2 neutral. All right, we have 2 more questions that I think we can go through pretty quickly because these are back to that, right? The imetelstat plus best supportive care versus luspatercept plus best supportive care. If I'm not mistaken, this is for the patient population with ring sideroblasts to match the previous. Yes. Okay, good. So then let's go to the voting questions, which you will now recognize pretty quickly. The first is about caregiver effects. Okay, again, this is imetelstat versus luspatercept. You did vote unanimously that there wasn't evidence to distinguish the two. And so I think we can go ahead and take a vote on this one. You guys can go ahead. There we go. All right, we've got 6 strongly disagree, 7 disagree, and 2 neutral. All right, if we go to the last of these questions before we sum them all up, again, this is about mechanism of action or method of delivery between imetelstat and luspatercept for patients who are eligible for either. Jeff, brief comment again.
IV every 4 weeks, sub-Q every 3 weeks. It sounds like both, in many cases, require a visit to a transfusion center, though we heard from our patient representative that it's just bundled with an office visit to see her hematologist. So there are other options, but it doesn't seem like there's any big advantage of imetelstat compared to luspatercept in terms of access, I think is the focus of this.
It is. Okay. Not seeing any questions. Let's go ahead and vote on that. Strongly disagree, 1, 5 strongly agree. Eight strongly disagree, 6 disagree, and 1 agree. Okay, let's go ahead and move to the last 2 questions on long-term value for money. Now I have to read a fairly long preamble here, and it's going to come after the patient population. So again, the first patient population is what I'll continue to call the all-comers with these criteria. And the voting question is, what is the long-term value for money of imetelstat plus best supportive care compared to best supportive care alone at the current pricing of imetelstat? And I will just mention again that we are asking the CTAF to integrate its consideration of the clinical effectiveness information and its certainty or uncertainty, these benefits beyond health and special priorities that we might hold important, and the cost effectiveness information. So Josh, do you mind, again, just kind of very briefly summarizing and telling them where in the tables they can find the cost effectiveness information relevant to that question?
Sure, Steve. So this is table 8 for this comparison, as well as table 10 for the cost effectiveness conclusions. And, largely we found large ICERs for this comparison on the order over $1 million per quality and per ELY.
Okay. So let's hear any thoughts or comments. And in this case, since it's a complex process to integrate all these things, I would encourage somebody who is willing to say, I'm going to vote X because here's how I'm putting it all together. All right. And I can always call him a victim, but there we go. Paul, you're our volunteer.
Yes, I think the question is, there's always uncertainty in these, although in this case, there's no uncertainty about the cost and that it's incredibly high. So for me, I would say the uncertainty in value with certainty in cost is by definition a low value state.
Okay, thank you. Anybody want to offer concurring or a different view or ask a question of somebody else at this point about the evidence? Joy. Oops, sorry, you're muted. There you go.
I would just concur with Paul. I mean, I think, not sure how much value it or how much benefit it offers in terms of clinical effectiveness and costs of very much more. So to me, that's got to be low value.
And just to remind again, listeners, to our process, we have this this kind of unusual term, value for money. That's to be really clear. We're not talking about whether it offers clinical value or value to the lives of patients and families. It's putting that in the context of the cost, the relative cost, and whether the value for the money is, as we say, in one of these different categories. Joan?
I did an article with the New York Times about a year ago about the cost of my medication. And I tell my family I'm a millionaire, and they're like, what are you talking about? I said, fortunately, my insurance company has paid a large percentage, and I have a high copay that I need other organizations to support me with. None of the drugs, as being an MDS patient, is the end all. It's a roller coaster of drugs from the beginning up until this point. As a patient, if we don't have these drugs, we're going to die, okay? That's based on the fact, because you can't keep having transfusions. And as I stated before, it's an option. And if this option is put on the table, it's going to save lives, okay? As I said, we're not in charge of the cost of these drugs, but and they all cost. I'm telling you, they all cost. Maybe not as high as the drug that I'm on now, or this particular drug, but it seems like more and more drugs that are coming out, the costs are always going to be higher than the last drug. So I'm not a scientific researcher or anything like that, but there must be some reason why that the drug costs are getting higher and higher and higher for this. This is a rare disease. And I know people know this is rare. It's not like your normal, I shouldn't say normal, breast cancer or colon cancer or prostate cancer. We don't even get the advertisements that you see on TV about medication. We don't get the marketing for our drug. So what I'm saying is, as a patient, if this drug can prolong my life for another 6 years or 7 years, and I don't have to be in the hospital having all these blood transfusions, I have no choice but to have a drug like this, and really no choice in reference to how it's going to be paid for. Thank you.
Thank you. Kavita?
Came up in our pre-call, and it's sort of related to patient out-of-pocket costs, right? So for a Medicare population, and then you reminded me that this drug would be, excuse me, covered under a Part B benefit. So some of the aspects of cap and out-of-pocket costs under IRA wouldn't apply to it. So I'm just curious if anyone out here, or especially the clinicians who've treated this population, how has cost sharing and affordability applied for the comparison drug? I'm just going to call it the L drug. And then for the policy experts here, Josh, maybe you can help with this. What are some of the expectations for Medicare coverage for out-of-pocket costs? The patient, what the patient out-of-pocket costs would be, given that this would be a Part B drug?
Kavita, I appreciate that question. It's a perfect one for our policy roundtable, which is where we are absolutely going to pick up aspects of the cost sharing and the coverage process, and which part of the coverage is, under Part B or Part D. So let's come back to that, and we'll address it face forward in just a little while. Any other questions or comments about your upcoming vote on luspatercept? Okay, for the all-comers population.
Not on.
Oh, heaven's sakes, there we go. Thank you, Jeff. That was a technical glitch. I actually didn't say luspatercept. You heard it, but it was a technical glitch. Yes, sorry, imetelstat. All right, let's show the voting question and make sure that everybody gets it right, me included. Okay, what is the long-term value for money of imetelstat plus best supportive care compared to best supportive care alone at current pricing? All right. High long-term value, intermediate long-term value, low long-term value, or the evidence is insufficient to make a value determination. All right, we have the results. Okay, we have 14 low and 1 evidence is insufficient. All right, we have one more of these all in, all in, by all in, I don't mean all patients, I mean all factors. So this time we are going back to talking just about the subpopulation of patients who are ring sideroblast positive, and for whom we can talk about the comparison, if you will, of imetelstat and luspatercept. So the voting question is, what is the long-term value for money of imetelstat plus best supportive care compared to luspatercept plus best supportive care at current pricing? Josh, I think you've already indicated which table it is, but you might as well go ahead and reframe it again and tell us what the ICERs were.
Sure, this is actually table 9, and then the ICERs are in table 10. Again, here we found it was more costly and less effective. That effectiveness component is very, very close, though. So you could almost call them equivalent in terms of the magnitude of difference there. But then the cost component is higher for imetelstat versus luspatercept.
Okay.
Did anybody hear anything in the discussion of benefits beyond health or special ethical priorities that they think will strongly influence their vote here or not? Okay. Just wanted to make sure we had a chance to hear that if it were the case. Patients or clinical experts, anything you'd like to add to their perspectives as they take a vote on this? It is the last voting question before the policy roundtable. Anything else you'd like to add? No? Okay. All right, let's go ahead and take the vote. All right, again, the choices are, and this is imetelstat versus luspatercept, high long-term value, intermediate long-term value, low long-term value, or evidence is insufficient to make any value determination. Okay, we've got 13 low and 2 insufficient. All right. Everybody take a deep breath. That concludes an important phase, but it really does serve as a preamble to talking about, if you will, the real world. How do we think about the application of the evidence